All right, hi everybody. I'm so happy to be back. Today I think I'm presenting on orthopedic considerations for pelvic pain. So Mike had asked me if I would come and basically do a pain lecture, but from an orthopedic perspective, and kind of what you can do from an orthopedic mindset to help people that have pelvic pain. So hopefully this will give you a little bit of a crash course in it. Please engage with me, ask me questions as we're going along through this, and hopefully I can answer your questions for you. So my disclosures: I am an assistant professor at Western University, so they pay me, and Certain Physical Therapy pays me as well. So just letting you know that I'm I guess indebted to them, and I'm indebted to you guys, and that's why I'm back. Some of the things we're going to go over today. So we're going to go over the bony architecture of the pelvis and just kind of review some anatomy landmarks, and also just the pelvic floor anatomy. So we'll take a look at the pelvic floor anatomy, we'll look at the ligaments and the bones that help support the pelvis. We'll also look at some musculoskeletal and visceral considerations as far as referral patterns go. So where, when these things hurt, where they kind of travel. And then some general ideas for treatment, but we'll be talking treatment kind of throughout today. So I love the pelvis. This is why I do what I do. So the bony architecture, this should look familiar. We have two innominate bones, we have a sacrum, and we have a pubic symphysis that kind of connects all of this together. These are load-bearing structures, so when we sit, when we stand, that is going to allow us to have some mobility and some play within those joints. And obviously, during different times within our life, some of us may have more play in those joints than others, especially if we think about during childbearing and carrying a child and delivering a child, that we have to have a lot of play within those bony structures. Just to remind you of all the ligaments that surround the pelvis here. So all of these are allowing for tension and closure of the pelvic arc, and can potentially be pain-generating structures when we start thinking about pelvic pain. And if any of the innominate bones or the sacrum or the coccyx get out of place, those non-contractile structures can be very painful. So to palpation, we can poke on some of those things and see if they produce pain. And there's our posterior ligaments supporting the pelvis as well. Some main ones that I want to draw attention to here. Oh, does my little thing work? Oh, there it is. There. Oh, I guess it doesn't work on here. But basically the sacrotuberous ligament and some of the sacrospinous ligaments, those are going to become kind of integrated into some of the muscles that are on the back side of the pelvis. And so I did this, and I know that this is kind of a gross view in some sense, but male and female anatomy kind of side by side. Some of the main structures of the superficial anatomy that I want you to be aware of, the ischial cavernosus are going to be these muscles that kind of align the sides of the pelvis, on either side here and here. And we have them in both male and female anatomy. Bulbospongiosus are going to be the muscles that kind of encircle the opening of the vagina and the base of the penis in the male anatomy. We have the superficial transverse perineal muscles, which are going to be here, and they kind of act like a bit of a pulley system, so they'll pull on either side of the pelvic muscles, and this is what all of these muscles are going to help with continence, with our ability to have a bowel movement, so on and so forth. And then external anal sphincter, that will be the back part here. And again, all of these muscles are going to kind of coalesce around a central tendon right in the center, which we call the perineum. With this, these muscles can potentially be tight, they can be painful, and they're all kind of in the area where you're sitting right now. So you can imagine if there's a problem in these muscles that people will report some pain sitting as well as pain with some other things. So the female anatomy here, this is going to be from the top down. We're looking at some of the deeper muscles, and these deeper muscles are going to be responsible for a couple different functions. They're responsible for supporting all of our pelvic organs against gravity. They're responsible for allowing blood flow into this area, so they kind of act like a muscle pump, and they pump blood down into the pelvis, and then they alleviate blood out of the pelvis. But what I want to point out is there's a couple of main structures that are not pelvic floor muscles that reside within the pelvis that still kind of interdigitate with the pelvic floor. So we have the piriformis that I want you to note back here that's attaching onto the back part of the anterior part of the sacrum, and then running its tendon out to the lateral hip. And then the obturator internus muscle, which is going to be residing on the inside of the pelvis. So both of those muscles have ligamentous connection to the pelvic floor. So our hip motions are very, very influential over our pelvic floor muscles, whether we can contract them, whether we can relax them. And so from that perspective, it's important to think about that from an orthopedic standpoint. If you have somebody coming in with some sort of a hip dysfunction, asking them maybe about some bowel and bladder questions or sexual pain, sexual function questions may be warranted given wherever their problem is. So any sort of acetabular impingement, any sort of radiating pain into the hip region, that might be appropriate. And then we have the longer muscles that are going to sweep through the pelvis that create our pelvic bowl. These are the ones that are going to be doing all the heavy lifting and supporting our organs against gravity. So we have the pubococcygeus going from the pubics to the coccyx. Iliococcygeus is going to be running towards that arc tendon of the obturator internus. And then we have the coccygeus, which in like kind of anatomical function, if we still had a full functioning tail, that would allow us to wag our tail. But for us as humans, that actually pulls the tailbone back after we've had a bowel movement. So our tailbone has to go into extension, and then the coccygeus both will contract to pull it back into position. So all of those we just talked about there. Okay, so the male pelvic floor deep anatomy looks fairly similar. The only big difference is look at the size of the opening here. So our female anatomy has a little bit bigger opening versus our male anatomy, and that unfortunately means that we have more of a risk of things falling through that opening. For men, we also have a little bit more tendinous and ligamentous structures that are going to wrap around the base of the prostate as well as the urethra. So they have a little bit more support in that region versus our female anatomy. So same sort of structures though. So pelvic organ support, so a nice little picture side by side here. What I want you to notice is kind of the nice little arc of our pelvic floor muscles, and our pelvic floor muscles in these pictures are going to be helping to support all of our organs against gravity. The red line is going to note kind of the ligamentous support. So I just kind of want you to see ligamentously how all these organs are suspended within the pelvis, juxtaposed to where the muscles actually sit. So again, the ligaments are passive structures. We really can't do a ton about tightening those up, but we potentially can give us a little bit more tightness from the muscles below if we need to. And for the female anatomy here, there's our pelvic floor muscles supporting all of our organs and keeping that nice angle. And approximately that would be where the ligamentous support is located. So again, if we lose some of that ligamentous support in our female anatomy, there's a larger opening for things to fall into. So I wanted to talk a little bit, so we're going to go back to anatomy and talk pelvic innervation. So hopefully this doesn't become painful and laborious for you guys. But so we'll start with the iliohypogastric. So iliohypogastric is going to branch off of the T12 to L1 segments. And that is going to be providing some sensation to your lateral glute. So if you can imagine kind of that peripheral nerve map where that would be supplying. So again, that is a lumbopelvic region nerve. And so if we start to think about patients coming in and reporting lateral glute pain, we might want to be checking sensory to that area. And also it's providing motor to the transverse abdominis. So if we have any sort of entrapment or problem in that area, the individual may not be able to get good transverse abdominis activation, which in turn also kind of leads to poor pelvic floor activation. We also have our ilioinguinal, and ilioinguinal is going to travel down right underneath the iliohypogastric there. It is L1 supply, and it is going to be providing a sensation to the medial thigh, the mons pubis, the labia, the root of the penis, and also the top of the scrotum. So again, if your patient is reporting maybe medial thigh pain, it might be appropriate to ask them if they're experiencing any pain or any loss of sensation within maybe their base of their penis or top of the scrotum if they're male, or the labia and mons if they're female. With this, ilioinguinal can get compressed sometimes because it starts to travel through the ilioinguinal canal. And we also have these two traveling, or the ilioinguinal nerves are going to travel along with the spermatic cord and also the round ligament of the uterus when it exits the body. So things can get pretty tight there. If you have somebody that's sitting at a desk for a long period of time or has to sit for work or drive, those can easily get compressed because of where they're located. Gen Fem, so that nerve, L1 and L2, sensory to the superior and anterior part of the thigh. And we're also getting a little bit of mons, labia, and top of the scrotum. No penis, root of the penis innervation for the Gen Fem. So again, with that, also travels through the inguinal canal, can be compressed on the ligament, can be compressed in that area where all those muscles have to kind of pass through. Lateral femoral cutaneous, L2 to L3, that's going to be providing sensory to our lateral thigh. It's going to branch off underneath the psoas, and so if we start to think about any of our anterior hip flexor muscles, psoas, iliacus, any of those become tight or painful to palpation, we might be getting referral patterns along those nerves to the lateral thigh as well. And lastly, for at least the anterior side, is our femoral nerve, and we know that that is going to pass through the femoral triangle. It's going to pass underneath the inguinal ring and the inguinal ligaments. And this is going to provide anterior sensation to the thigh, as well as our motor to our anterior compartment. So if we start to see, again, some pain referring along that pattern to the anterior thigh, we might think that it's a femoral nerve compression, and we might want to go dive in and check that out either at the anterior, opening of the, where the nerve's exiting out, or further up into the abdomen. Oh, and sorry, one more, obturator. So this is going to provide L2 to L4, so sensory to the medial thigh. And we're going to get motor to the adductor compartment, so all of our adductor muscles are going to be innervated by that. So again, referral pain from that region could potentially refer along the adductor compartment, and so somebody might report high adductor pain, as well as maybe some pain in the obturator externus tendon. So for posterior innervation, we have a couple of nerves, and again, I didn't include the sciatic nerve in this group because I think we all deal with the sciatic nerve quite a bit. But these two are the two that we tend not to see as frequently, and that is the nerve to obturator internus, which is providing motor to the obturator internus muscle, and then the pudendal nerve, which is providing sensory, motor, and autonomic functions to all of our pelvic region. So it's a very special nerve in the sense that there's autonomic function that's traveling on there, and so a lot of the times when I have patients that have pudendal nerve issues, they might report, when their pain symptoms come on, that they might start getting racing heart rates and sweating and those sort of things that would be indicative of some sympathetic kind of innervation. So interesting. But I have this so that you can see. So this is the back side of your pelvis, right? This would be your piriformis muscle. And we have your pudendal nerve coming out of the sacrum, and it's wrapping underneath here. Let's see if I can get this going. Underneath here. So it goes out the greater, in through the lesser, and then it travels down the base of your pelvis. So let's see if I can get this going. So there. So that's pretty much what it looks like, and it's traveling along the inside of the ischial tuberosities. So unfortunately we have that nice bony protection, but the pudendal nerve is oftentimes compressed because of how much we sit these days. So I do see a lot of individuals that have pudendal nerve pain, and sometimes we can get an overflow where people will have sciatic pain, so they have pain going down the back of the legs, but they also have pain radiating into their perineum, posterior part of the scrotum, and backside kind of around the rectum. Okay, so some conditions. So this is not an exhaustive list, but these are some things, and again, as a pelvic floor physical therapist, I have to be a good orthopedic therapist first, because I don't want to have to dive in and treat everything directly if I can do some stuff and make some changes indirectly. So any sort of joint pain, if we're talking from lumbar pain to sacroiliac pain, sacrococcygeal pain, pubic or femoral acetabular pain, all of those can be treated in an external fashion, and I think that your standard joint mobs and things like that, muscle energy techniques, and even some of the movement stuff would be warranted to treat any of those things. For bladder pain conditions, we typically hear the diagnosis interstitial cystitis, or now they're calling it painful bladder syndrome, and that would be somebody reporting UTI-like symptoms. So they might be experiencing burning with urination, frequent urination, or have had a history of having frequent UTIs. And I think on your intake forms you guys ask about bowel and bladder stuff as far as just a general medical screening, and so if somebody says yes, this might be a time to dive in and ask maybe some deeper questions as to what that might be. Rectal pain. So this could be due to constipation. Obviously, if we've got something sitting near the opening and not able to leave, that could be uncomfortable. IBS-like symptoms, and especially IBS with constipation, can be an issue. People can have anal spasms, and usually what anal spasms look like are they're not able to have complete bowel movements, and so they'll kind of half have a bowel movement, and then there's still more left over that they feel that they need to get out later. Obturator internus syndrome. So obturator internus, as far as a referral pattern goes, can actually refer to the rectal region. And so if somebody has a nerve compression of the nerve to obturator internus or irritation in that nerve, they might be presenting with rectal pain. And then piriformis syndrome, because the piriformis and because of where all these nerves have to pass underneath the piriformis, if the piriformis becomes fibrotic or if it becomes inflamed, we can potentially get some compression here, and that can lead to problems further down the chain. With our uterine pain, we typically see things like dysmenorrhea, which is painful periods, and endometriosis, which would be a condition where the endometrial tissue does not reside within the uterus. They have infiltrates that are elsewhere in the body. And that can cause a lot of pain when they are on their cycle and also when they're off their cycle. And a lot of the patients will be treated by actually taking birth control continuously so they won't have a period, but they still may have some pain. With vulvar pain, we typically see diagnoses like dyspareunia, which is just kind of painful intercourse, vestibulodynia and vulvodynia, so pain in the vestibule, which is close to the opening, and vulvodynia, which is the entire external structure of the vagina. And then pudendal neuralgia. So the pudendal nerve, because it passes in that region, can present with some pain and issues. And there's one condition that's called PGAD, which is persistent genital arousal disorder. So these individuals feel like they're kind of on the point of orgasm continuously, which sounds nice until that happens, when you're in a board meeting. So that is a unfortunate offshoot of pudendal neuralgia, and it's difficult to treat. But again, through physical therapy and through some orthopedic and pelvic floor things, we can potentially create some changes. So penis and scrotal pain, again, that could also be a pudendal neuralgia issue, so the irritation within the pudendal nerve. Pelvic congestion. So pelvic congestion is when your pelvic floor muscles get so tight that typically after orgasm that the blood gets trapped down in the pelvis, and so they get like this really uncomfortable heaviness and just not fun feeling down there. A varicocele is like a varicose vein, but in the scrotum. So at some point in time, if somebody's reported that on their medical intake, you might want to ask them if they've had a surgical repair of that. And again, that could be blood getting kind of trapped down in the scrotum, and it can be very heavy and uncomfortable. And then any sort of nerve entrapment or compression within any of the nerves that are coming out of the spine or in the pelvis. And lastly, testicular pain. This could be due to an inguinal hernia, and that's whether they have an active hernia or the hernia has been repaired. Sometimes the spermatic cord and the cremaster muscle get caught in the mesh that they put in the anterior wall, and you can imagine every single time your testicles kind of have to move or raise and lower that kind of rubs on that mesh, which is not so fun. We can get testicular pain from an adductor strain. So I've seen some very, very high adductor strains because it attaches onto the inferior ramus of the pubis, so right here, and kind of meeting right where the testicles and the scrotum are coming out of the body. And then also we can have a cremaster muscle spasm. So the cremaster muscles are the muscles that are responsible for raising and lowering the testicles with heat or with cold. And they attach actually on the superior pelvic pubic rim and then pass through the inguinal canal and wrap around the testicles. So they are responsible for raising and lowering. And I've had some patients that have actually had spasms in that. And so they get a kind of a presentation where one of their testicles is higher than the other. But if by working through the abdomen or working on that pubic rim, you can actually try and relax some of the muscles. And you can teach the patient to actually do their own stretching to their testicles to get things to relax, which I know that sounds kind of weird, but it works. And then any sort of abdominal pain, and we'll talk a little bit about why abdominal pain, and especially with my male patients, is so important, because the scrotum and the testicles actually start up in the abdomen, or not the scrotum, but the testicles start up in the abdomen, and when they descend, they take some of the abdominal wall with it. And so any abdominal pain can refer down into the pelvic region as well. So I've seen everything from, some GI upset to people reporting testicular pain to, obviously they've had an insult in that area and that potentially causes pain in that region. Okay, so let's talk about some referral patterns. So again, this is more clinically based as far as my clinical experience and just what, I've learned in my studies. But these pictures are from the Travell and Simons Trigger Point book, if you will. So Levator ani referral. So if we're talking about musculoskeletal referral patterns or musculoskeletal trigger points within that would refer to this area, this is kind of our typical Levator ani presentation. So if somebody has a trigger point within the Levator ani, this might be what they're reporting as far as pain goes. With this, orthopedically, we can actually impact some of these muscles. Now, again, I would say with clothes on, with permission, right, with explanation. But working near the tailbone you potentially can actually activate some of these areas and be able to release trigger points if they're reporting pain in that area. And also they might experience difficulty with bowel movements and those sort of things that might go along with this clinical presentation. So here's your obturator internus referral pattern. So again, if you're working externally, it's really difficult to get to the obturator internus, but we might be able to influence some of the structures that support the obturator internus. And this would be working on the hips. Again, obturator internus is going to be an internal rotator of the hip. So doing any sort of our mobilizations that would allow for more internal rotation may slacken that muscle to some extent, as well as working on any of the nerve referral patterns. So if we go back to that nerve to obturator internus and where it comes out of and where it goes, it's coming out of the lumbar spine. So theoretically, we could potentially do joint mobs at the lumbar spine to off-put or to send better information down that nerve to these areas. So again, it doesn't always have to be direct. Sometimes we can go indirect. And I do that a lot with my patients, especially if I have a nerve that's really, really irritated and can't handle me touching it directly. Piriformis. So here's our piriformis referral pattern, and again, we can go direct or indirect with that as well. We can work along the length of the piriformis. We can do things as far as movement goes, moving the hip to put the piriformis in either a lengthened or a shortened position depending on what we want. We can also play with the flexion or extension of the hip because at certain degrees of flexion, the piriformis is an external rotator, and then in certain degrees of extension, it actually acts as an internal rotator. So be thinking about that as far as where your patient is having pain and maybe how you might want to play with that positioning of the hip to address those trigger points and address the trigger points in those positions as well. Now, for me, I can palpate the piriformis internally, but that is typically not the first go. And most of my patients that come in with some sort of a piriformis referral pattern will have had their piriformis worked on externally, and they've said that it does reduce their pain to some extent, but then they still have a little bit that resides, and that's where I come in. Also, if we're thinking direct versus indirect, we can press on the piriformis, or we could mobilize the sacrum. And if we mobilize the sacrum, we may be changing the tension on that muscle and might be changing the pain. So here's our iliacus and psoas. So iliacus and psoas are iliacus is going to rise from the iliac crest and attach down onto the anterior thigh, and then psoas is coming from the lumbar spine. So again, we could potentially do joint mobs within the lumbar spine to affect that muscle, as well as maybe doing some deeper palpation through the abdominal wall and doing some soft tissue along the iliac crest or along the whole length of the psoas. And also, the hardest part is getting to where it inserts, right in the femoral triangle. And so potentially moving the hip in a position that might allow us to have better access there. Also, any of those nerves that kind of came out of the lumbar and sacral plexus that overlay this muscle, if we treat these areas, we might be also affecting those nerves. And so if we're suspecting that the person has a nerve problem in that region, that we can go after the muscles there, and it might get kind of overflow into the nerves as well. So the adductor referral, so this one I think is the most interesting as far as if we look at a referral pattern point. So for Travell and Simons, they said, okay, here's adductor magnus, right? So we get the inner part of the thigh, but they actually showed part of the pelvic floor, and they said it's referring up into the inner part of the pelvic floor. So somebody that has a high adductor strain may report that they're having, internal pelvic floor kind of area issues. So they might be reporting that there's, pain with intercourse. They might be reporting that there's pain sitting or pain, doing any other things that would happen in that region. Also, for you to note, the adductor longus and brevis, kind of where they refer, similar sort of a pattern, but they just don't have the internal pelvic floor piece. And then our gracilis is going to be, a little bit more medial. And then pectineus does sit really close to the groin region, and so that too also has some referral into the lower abdomen and the anterior thigh as well. All right, so the pelvic viscera. So anybody do visceral stuff? Any visceral people around? Okay. All right. No. Okay. Just well, I encourage everybody to treat the viscera, whether it's direct or indirect. The viscera can really have a profound impact on kind of what happens, and it's something that we can do externally, and we can create a lot of change. So hopefully, I will convince all of you by the end of this to maybe go seek out some visceral courses because they're really cool. But if not, I think that as an orthopedist and as just with a sense of anatomy, you should be able to target these organs and treat them nonetheless. But what I want you to realize is that visceral pain is kind of coming from a couple different places. One can be the direct innervation, and so we have a referral pattern. So everybody remembers from their medical screening courses, right, that you have this visceral organ that's going to refer along this nerve area to the skin. And so for any of these organs, this is kind of the general visceral pain innervation pattern that we see. So this is where your heart attack may look like left shoulder pain, sort of a setup. Also realize that there might be fascial lines in which these organs are going to refer across, and partially because the fascia that supports them within the body cavity might have connections to the spine or to the pelvis or to other bony structures. And then lastly, embryological development. So like I said, with the testicles, they started up in the body, right? As they descended, they took something along with it. And so as far as embryology goes, things that come from the same layer, so if they're all from, the organs are from the mesodermal layer, then they may have a similar referral pattern where they might refer to other things that are from the mesoderm. So interesting stuff. So as far as the testicles, if we consider the testicles an organ, which I do, the testicular referral pattern looks very similar to an abdominal referral pattern. And again, it's because they took their place up in the abdomen first and then made their descent down into the scrotum. So what I want you to notice is that it does look like the lower end of this picture that we might be getting referred pain along the iliac crest, down into the testicles, and it may refer all the way up as high as the diaphragm. So depending on how long the pain's been going on, all the stress features that kind of are involved. And so I encourage people to poke along the abdominal wall, see if that reproduces pain. I've had patients that I've worked on where I start working up maybe by their diaphragm and right underneath their rib cage, and they go, wow, that refers all the way down. And, you know, again, not necessarily a direct one-to-one, but we can see that with the connection between the abdominal wall and maybe some of the innervation that's there. The other thing I want to show you is in this picture here, we have a really nice picture of some of the abdominal wall. So here's your transverse abdominis and internal oblique muscles and external obliques. And then this blue line around is actually the abdominal fascia. So that thick layer of fascia that's underneath all of our abdominal muscles. So when the testicles descend, they basically create the spermatic cord, and we take some of the abdominal musculature as well as the abdominal fascia as they head into the scrotum. So anytime something happens in the abdominal wall, something will happen to the testicles, and anytime something happens in the testicles, something will happen to the abdominal wall. So it's really nice to be able to see that kind of in situ and see how that connection goes. Okay, so scrotum referral pattern, and this is a little bit hard to see on here, but this is actually a peripheral nerve, sensory nerve map of some of the nerves that we've already talked about and some of the ones that we haven't talked about yet. But we can see the center here, dead center is going to be our pudendal nerve. Iliohypogastric is going to get the mons pubis area for this gentleman, and then ilioinguinal is going to get kind of the top part of the scrotum, base of the penis. And then our posterior femoral cutaneous nerve is going to get that entire purple area. And then in the back, we have some things that are starting to come from the cluneal nerves, which are these really teeny tiny nerves that kind of come off of our buttocks region and travel down to innervate the sensory, where our gluteal cleft is. Okay. So all of those nerves potentially could be entrapped or could be inflamed, or we could have scarring in those areas depending on what surgeries have been done and could be compressed upon. So again, if we start thinking about where the nerves come out, they're coming out at the lumbar region, they're coming out at the sacral region. So I argue that lumbar and sacral mobilizations potentially would be helpful to give these nerves better communication, as well as maybe thinking about how you could position the body in order to glide the nerves. So penis referral pattern, very similar to what we saw before here in the scrotum referral pattern, except for we're looking a little bit more at the anterior part of the thigh, just because the penis sits a little bit more anterior. We can see the iliohypogastric nerves again, and the lumbosacral nerves as they kind of wrap around the inner thigh. And they can refer down the leg. So I've had a lot of patients that may have pain at the base of their penis report that they have pain all the way down to their knee. on the inside of their leg. And so again, thinking about the where the nerves are coming out of the spine, mobilizations to those areas, as well as maybe some nerve glides or positioning could potentially help somebody that's having pain referred into those regions. So the vulva, this picture is very similar to the one you just saw. So looking at iliohypogastric again is going to go to the mons. Ilioinguinal is going to go to kind of the upper part of the labia and the clitoris. And then pudendal is going to kind of embody everything else. And then we have the cluneal nerves as well that are going to be coming into play at the posterior glute. So, if somebody is reporting pain where they sit, burning in their vulva, painful intercourse, sensory issues in this area, that could potentially be warranted, as well as treatment to that area. All right, so I wanted to show you guys some of the ligaments. And again, this is part of my argument why treating the viscera is such a great thing and can impact people, just help people in such a great way. First of all, the uterus is innervated by the sympathetic nerves from levels of T10 to L1. So joint mobilizations over the thoracic spine or joint mobilizations over the lumbar spine could potentially help with a sympathetic downregulation to the uterus. And our parasympathetics are from S2 to S4. Again, treating the sacral region as well could potentially give some good input into the uterus itself. And then as far as suspension goes, we have the broad ligament that's going to sweep from side to side and basically hold the uterus stable within the pelvis. We also have a round ligament, and the round ligament is going to be, it's the same as the why am I losing my thought process right now? The spermatic cord. So the round ligament in the female anatomy goes through the inguinal canal, the deep and the superficial rings, and actually attaches to the labia. So a lot of times when women experience round ligament pain during pregnancy, their uterus stretches and stretches, and they'll feel pain radiating from the uterus down into the labia and maybe down into the inner thigh. The cardinal ligaments are going to be the ones that are on either side of the cervix. That's going to help support the cervix and keep the cervix in place. We have a pubocervical ligament, which is also going to help support the cervix, and the uterosacral ligament. So the uterus is actually connected directly onto the sacrum. So for a lot of my patients that have pain during their menstrual cycle, whether it's while they're on their period, whether it's somewhere along their cycle during ovulation, a lot of the times I'll dive in and actually do some of those ligamentous structures that can potentially influence the tension and how much the uterus is pulling on that area. Also, we could potentially move the pubic from the pubic bone backwards, and that would also help to offload some things. Yeah, and then this is a nice little picture here, so you can see how all this is attached, pubis all the way back to sacrum tailbone, and so that any mobilizations in those regions potentially could help with offloading those structures. Yeah.
I used to do a lot of visceral mobs maybe about 2 years ago.
Uh-huh.
And then I probably have a 90% success rate.
Okay.
So 9 out of 10 patients actually have significant improvements.
Uh-huh.
I guess as I started school, a lot of this stuff started moving toward the clinical practice guidelines.
Mm-hmm.
And none of this stuff that
I know
was really successful was included in there or was even suggested to use.
Yeah, and that is our hole in our evidence, and that's why like I say, this comes from a lot of clinical experience. I don't have good evidence to back this up yet, other than I've done this on my patients, and they're happy, they're pain-free. So that is where it's hard. It's really, really hard for us to figure out how we're going to measure these things and how we're going to quantify the change that we're seeing clinically in these patients with this type of treatment. But I think that anatomy doesn't lie, right? If I know that the anatomy is connecting the sacrum to the pubic bone to the uterus, if I treat the uterus, I might offload the sacrum. If I treat the sacrum, I might offload the uterus. So I think that how we actually prove that, I have no idea.
In my case, the functional scores actually shot up.
Yeah.
And then I was wondering if you would stick it in the evidence pyramid, where would you place it as far as when would you start using it?
When would I start using this? Like visceral treatments? First and foremost. So I start with, again, my perspective is I want to do as much externally as possible to help that's the low-hanging fruit, if you will. I have some patients that aren't able to take a vaginal exam, an internal vaginal exam. I have some patients that, maybe are too young to have an internal vaginal exam. So I need to figure out, ways that I'm going to help them. And this is usually it also, for me, it's a rapport builder too. I mean, it's really difficult in my setting to walk in and it's like, hi, you're going to take your clothes off and I'm going to be, poking around in there. So if I can do something externally and have them buy into what I'm actually doing first, then they're a little bit more likely to let me examine things internally as well. So for me, this happens early and it happens often. Yeah. No, that's fine. Sorry, I will definitely repeat it. So bladder pain and bladder referral patterns. Let's see, how am I doing on time? Okay, I'm doing okay on time. Innervation. So we have the sympathetic coming from the inferior hypogastric plexus, and we have the and that's within the thoracolumbar region. And then we also have parasympathetic that's coming into the pelvic splanchnic nerves. So again, we can potentially, if you remember back to anatomy, you have your sympathetic chain ganglion that sit along the lumbosacral region. So if we do joint mobs there, we potentially are opening up channels within the sympathetic nerve, so that might be helpful. In the bladder's case, sympathetic helps us store more urine. So if somebody's having urine incontinence issues, that might be someplace distal to try to see if that actually helps their bladder storage capacity. The parasympathetics help with urination, and so if they're having overactive bladder issues or if they're having issues with emptying completely, that actually treating the sacrum potentially could help with parasympathetic innervation and allow them to pee better. Also, we have fascial suspension system that helps us support our bladder within the pelvis. So we have the lliacus ligament. So I did this for you guys here. So this is the lliacus ligament. So the lliacus ligament goes from the belly button to the top. So this is like if I was to cut you in half and we're looking at the back side of the abdominal wall forward. We have the bladder. We have this very, very thick connective tissue that connects directly to our umbilicus. And this is actually our very first scar. When we're a baby, we have an umbilical cord. They cut the umbilical cord, it scars down. So that was actually part of our fetal blood supply, and it runs along the inside of the abdominal wall, connecting directly to the bladder. So a lot of the times, when people have bladder pain, they also report that they're having this lower abdominal umbilical pain. So that's something that's kind of easy and easy to access, that I could basically maybe do some fascial mobilization to the skin and the abdominal wall underneath their umbilicus and get some bladder relief. I actually have one patient that was telling me that in order for her to empty her bladder completely, she presses her belly button and it lets go. So that's, a very interesting connection there. Just a fun fact, though, that the umbilicus, this lliacus ligament, actually comes all the way up and attaches to the round ligament of the liver and the falciform ligament of the liver. So thinking about diaphragmatic breathing, diaphragmatic movement, even pressing a little bit down on the liver to try and get it to drop away from the diaphragm, potentially will offload this ligament and potentially offload the bladder going forward. We have a pubovesical ligament, so that one is going to wrap from the pubis directly around the top part of the bladder. So again, anything from the front, the pubic bone, we can potentially offload the bladder anterior to posterior. We also have the uterovesical ligament, so anything we're doing to the uterus may also affect the bladder in turn. We also have a urethrovesical ligament, so that one is sitting a little bit lower. And we have the urogenital diaphragm. So the urogenital diaphragm is going to span directly across the pelvis, so it'll actually be through this region. Again, if we're not in a pelvic floor setting, I might want to encourage a patient to actually press in on these areas on either side. And again, that can help offload the bladder from the bottom up and might give them better filling capacity and better emptying capacity. So just something to think about. And then the vesicosacral ligament. So again, we have the bladder connecting to the uterus, connecting back to the sacrum. So potentially, if I did something bimanual and I offloaded both the sacrum and the pubic bone, that I was offloading the bladder as well as the uterus. So just some thoughts on that. So for rectal referral pattern, the innervation is exactly the same as the bladder. So they get information from the hypogastric nerves that are going to be providing from the thoracolumbar region, and we also have parasympathetics coming from the pelvic splanchnic nerves. So again, our thoracic spine, lumbar spine, and sacral lobes potentially could be influencing our rectum. And fascial, we have a rectouterine ligament, so anything that we're mobilizing through the uterus, we might also be getting some rectum there. We also have a rectal vaginal ligament, And we have a rectal sacral ligament. So again, anything on the sacrum, we can potentially offload the tension structures from anterior to posterior. Okay, so treatment considerations we talked about. So joint mobilizations, thoracic, lumbar, and pelvic girdle mobs would be appropriate. And again, that would just be based on what you think that your patient can tolerate and handle. A lot of my patients, I tend to stick to kind of the lower and mid-grade mobilizations, and I tend not to be doing a whole lot of high-velocity thrusts in my office, but a lot of muscle energy things. And that partially, the patient feels like they have a little bit more control over their movement and control over the force that's going into their body. Soft tissue mobilization. So we could use this to address those trigger points like the Travell and Simon pictures. We could use this to help fascial mobility, and that's fascial mobility whether we're talking about the fascia of the superficial sensory nerves or the fascia that is suspending some of the different organs within the abdominal wall. And also we're using this to improve blood flow, because if we open up these channels, we potentially are getting better blood flow to those regions. So our nerve mobilization, we can go ahead and mobilize the nerves of the lumbosacral plexus, which we looked at today. We can also do some sympathetic and parasympathetic nerves, and that would be a little bit more direct versus indirect, right? Because we can't get directly onto those nerves, but we potentially can do some things within the spine that would influence those nerve channels as they come out. So visceral mobilization. We can go ahead and treat the associated structures. So if somebody says I have bladder pain, we can treat bladder pain, we can treat the bladder, we can treat the rectum. Through the abdominal wall, and we can also treat the uterus. So those are all good things. And then from a perspective of tension, we can potentially try and offload any of those suspensory ligaments that we talked about earlier. So whether that's through joint mobilization, whether that's through something through the abdominal wall where we're trying to compress things and offload the suspension. And any sort of movement and postural re-education. Again, I think that a lot of the times why we develop trigger points in these areas, or why we develop poor fascial mobility or nerve mobility in these areas, is because we sit or we put ourselves in a position that may not be the most optimal position. So looking at offloading the muscles and the nerves, as well as the fascial components, can be really, really important, as well as improving mobility and blood flow. And I know that you guys have done a lot of movement system stuff since Mike's done his fellowship, and so any of the movement system things apply here as far as retraining the body to move in a better way, a more optimal way that will in turn kind of float down and help this. But ultimately, if the patient is getting a little bit better, but if you kind of don't know what to do, refer to pelvic PT. And you guys have a couple of pelvic PTs as part of your department, so that's great. You have that referral, and have them put the eyes on the situation. But it's one of those, if you don't ask the question, you won't know that somebody's having pelvic pain or pelvic issues. And so be brave to ask, are you peeing your pants? Are you, having pain with intercourse? Those are things that, from our perspective, we are medical people, and we should be asking those questions. And again, these can kind of go in conjunction with any of those pains in any of the areas that I talked about. So somebody has hip pain, they may be having pain with intercourse as well. And so I think that if you put that kind of on your radar, then it becomes easier to ask those questions when you're screening, and it doesn't make you creepy, I guess, at the end of the day. So other helpful resources, American Section on Women's Health, APTA, they have amazing resources available. The Herman and Wallace Institute also. The International Pelvic Pain Society, and then our website. Follow us on Instagram and Twitter. We've got pretty active Instagram and Twitter following, so we're always posting good things. So these are my references. So pretty much Netters and my Travell and Simons, and most of it was my own clinical kind of journey. And then special thanks to you guys, because I don't know if I'd be standing here if it wasn't for your tutelage. So much love. And so, any questions? Well, yeah, so I would say that the Barral Institute, they have the visceral classes. If you want one that's more specific to urogynecology, they do have one that's offered typically through the APTA's Women's Health section, and it's taught by Gail Wetzler, and she's kind of one of the visceral gurus, and she does just kind of mobilization to the viscera, so you can learn how to do that. The Barral Institute, I think it's like VM3 for them, and then also Herman and Wallace, the other group here, Herman and Wallace has some visceral courses as well. But realize that in the context of this, if you're learning about gynecological visceral mobilization, likely there will be some internal work that goes hand in hand with that course. So just prepare yourself for that. Just because we're looking at mobilizing the viscera both internally and externally, I don't know if everybody wants to go there, but just be mindful of that. But I think that, again, with a good sense of anatomy and a good sense of where these structures reside and kind of what suspensory ligaments they're attached onto, I think that anybody can do visceral. I don't think you necessarily need to be trained in it, you know, through class. But there are some amazing classes out there if you're interested. Yeah. Uh-huh. Uh-huh. Okay. Yeah, you want me to show you? Okay. Can I have a volunteer? So I tend to, especially with the lumbar spine, I tend to treat my patients in sitting first, and just because typically they're sitting there talking with me, and they also have pain in sitting. And so if I'm trying to influence their pelvic pain when they're sitting, it's easy to treat them in sitting. Now the other thing too is I tend to use a lot of bolsters and props in my office. So I might have a patient sitting on some sort of a cushion that's going to offload their pudendal nerve so that they're not sitting directly on it. But I'm going to have you bring this hip forward just a little bit. Perfect. I'm just going to lift this up so I can see your low back. Okay, so I just have the person so just sitting in neutral. And I'm just going to be feeling for the lumbar spine transverse processes here. Okay, and I'm going to have you go into a slouched position. So I'm feeling for which direction the lumbar spine doesn't want to move, and I'm going to have you go back into extension. So she's better in extension, go into a slouch again, and she's a little bit worse in flexion. So I'm going to, and I feel this side more prominent than this side. So I'm going to hold on this side, and I'm actually going to have you rotate this direction. And I'm going to give you a little pressure here, and don't let me move you. And I'm just going to have you breathe. Any pain with this? Okay, breathing nice and deep. And I'm just going to hold for a few seconds until I feel that shift underneath my finger. And then coming on back to the center here. And then we go back. So same thing, I'll have you slouching again so you can work all the way up the spine this way. Once you get up to the thoracic spine, it's a little bit harder to do in sitting, but you can influence it to some extent in sitting. And sitting up nice and tall. Okay, go back into your slouch again. And then rotating a little bit here. It's just more prominent. So it's more of a, it's not wanting to rotate that direction when she goes into flexion, so I'm helping it. And she's helping it by resisting me. Mm-hmm. Yeah, so it's really gentle, and I use this a lot on my patients, not only that are in pain, but also my patients that might be experiencing hypomobility during their pregnancy. And so, again, you don't want to press on them too much because their joints move very easily. But again, we might be using a set of different, myofascial treatment techniques to try and calm the nervous system down, as well as elongate the muscles or let the muscles relax a little bit more. My sacral one, that one is one of my favorites to do. So that one I'm actually going to have you lying prone. So I know, I think the sacral one that we typically learn is the one where you've got like one leg up on the table and one leg down off the table, and you kind of have the person really flexed, but you can actually achieve the same result with the person just prone. So let me see, where's my up and down on this table?
The brown cord.
Oh, yeah, it's the traction table, huh? I'm just going to be feeling the top part of your sacrum, okay? So actually, let me grab y'all can see. So I'm going to pull my pudendal nerve out. So what I'm feeling for is I'm feeling for the lateral borders of the sacrum and kind of where the sacrum and the pelvis are coming together. And I'm feeling for any sort of rotation within the sacrum. So if the sacrum is sitting more elevated on one side, if it's flat, if it's turned at all, that's what I'm feeling for. And again, we can potentially provide some pressure in order to kind of flatten it out. And again, I'm offloading, if I'm pressing through with her in prone, I'm offloading all of the structures in between. So again, a lot of the times if my patients have some sort of visceral pain, that this is really, for the most part, very comforting to them. I'm just going to be feeling here. Feeling down the lateral sides here. So right now, I'm seeing that her sacrum's actually rotated this direction. So her sacrum is turned this way, like that. So this side's more elevated. This bony prominence is sticking more towards this side. So I'm going to try and gently guide it back over to the other side. And again, putting some downward pressure will allow me to offload everything in between. Yes. Or sorry, your right side's elevated. I'm just going to give you a little pressure here. Are you okay with that pressure? And this pressure? Doing okay with that? I'm going to have you gently press your right knee down into the table. Breathing. Relaxing. I'm having her basically go into flexion, so she's pushing the knee directly down into the table. So with that, when she presses her knee down, if I've got pressure here and I'm pushing down here, she pushes her knee down and she's basically giving me space to move her sacrum. So I'll do this a couple of times until you feel that end, that prominent side kind of drop back down. So go and press in again. Good, and relaxing. A little pop there. Okay, one more time, pressing. No pain with this? Okay. A little? Okay. And relaxing. So of course I would do, like a Marge test and all that kind of stuff ahead of time, as well as just feeling the lateral borders. Okay, so that one I really like to do too. But those are kind of my main muscle energy techniques that I tend to use in the pelvis, as well as the visceral techniques in addition. So sometimes I'll do like a sacral float where I'll have the patient lying on my hand and they're supine on the table and I'm putting pressure upwards, and then I have a hold of their kind of abdominal bulk and I'm pressing downwards. So I'm basically offloading from either side. Yeah. Oh, there are a couple. Probably my favorite one. Well, let's see. So my favorite one to do is with the patient in supine. She might. Okay, so the pudendal nerve. Oh, let me put this back. So the pudendal nerve is coming out of here, right? It's coming through here, in the greater, out the lesser, and then down the side. Okay, so what position do you think would make this more taut? Okay, so sitting directly on it, we definitely have some compression, but sitting and then which position of my pelvis? Posterior pelvic tilt, and then adduction or abduction of the leg? Abduction, yeah. So, I'll put my patient, I'll bend up her knees. So she's already going to go into a little bit of a posterior pelvic tilt. I'll have her go knee to chest here. And then I kind of gently glide out this way. So it looks very similar to any sort of like a hip scour test. Now again, I can have this dialed up or dialed down by having her go into more posterior rotation and less posterior rotation. So this is the offloaded version. I can also have patients do like a squatted position. So they get down into a really deep squat, which I don't know if I can do in the dress right now, but they go into a really deep squatted position and then they're tucking their tail under. And that's going to go ahead and tension that pudendal. Mm-hmm. And so you can have them, I can have them in this position and they can go ahead and move the knee up and down to offload it. They can move the hip in and out to offload it. They can do hip extension flexion to offload it. They can even wind up the dura and do a little bit of head flexion if they want.
And then just even to get just...
Yeah, or the pelvis. Yeah, so that's always a good one. Same thing with obturator nerves. Obturator nerve is very similar, except for I do that one in sitting. Let me bring you back down here. So it looks kind of similar to the slump test. Let's see. Is this sturdy on this side? I can have you sit on this end without you falling off the table. Okay, so I'll have you sitting actually on the corner. So you're going to kind of straddle the corner. So So this, you're going to have them go into the slump position. So you'll have them crisscross, head down, tucking here, and then you're going to have them bring their leg into external rotation and then abduction, and then internal rotation and adduction. And so you can have them go back and forth between the hip, the knee. Also, you can have them do a pelvic tilt, either anterior or posterior, to offload or load, or you can have them increase the yeah, it's a lot of movement. Yeah. But all of that is potentially gliding the nerve through that obturator canal as it passes through. Or you can have them do like more of a dural head up and head down sort of thing. All right. Yeah, no problem. No, I'm happy to do it. Any other questions? Any other things that I can? Yeah.
Case of adductor tightness, could that be a cause for scrotum pain?
Yes, absolutely. Yeah. So. Okay.
Yeah.
And so did they?
Walking hurts him.
Yeah, and it felt like things were getting smashed, and so he had to walk like this, huh? Yeah. So did he come in reporting scrotal pain, or did he come in reporting just the adductor pain, and then it kind of manifested itself in the scrotum?
Yeah. So basically, he complained of adductor pain and the pain that he can't sit or he can't walk with the legs.
Close, yeah, kind of in normal alignment, right? Yeah, so absolutely, that can refer into the scrotum, and it can also, working on some of the stuff from the insertion of the adductor high in the adductor kind of inferior pubic rami might be warranted. But again, it's hard. It's hard to have a conversation with a patient like, I need to go all the way up here, and sometimes in the outpatient world that's not the easiest thing to do. But yeah, absolutely. Anything else? No? All right. Well, thank you guys. Thank you for having me. I hope I provided something.